Good afternoon, everyone. I'm Dr. Anup Menon. Today I'll be talking about hyponatremia and hypernatremia, the various clinical scenarios in which you encounter these problems, these electrolyte problems, and how do you go about evaluating each. Okay. So whenever we think about hyponatremia, most of us, when we see patients for the first time, we see a lot of cases in which patient presents with altered sensorium, or which in medical terms we call encephalopathy. So even if a patient is in coma or in varying stages of encephalopathy, the main thing that we need to remember is the four clinical scenarios where encephalopathy is encountered. You can have hepatic encephalopathy, you can have uremic encephalopathy, hypercarbic encephalopathy, and also the fourth one is metabolic encephalopathy. So the initial task is to distinguish between a CNS cause of encephalopathy. You want to know whether the patient has got a stroke or a space occupying lesion which is causing the encephalopathy. So what do? You give some kind of a stimulus. Like for example, if the patient is in a reduced state of consciousness, you give a painful stimulus. If there is any lateralization, that is if there is a paucity of movement or motor response on one particular side, it may give you a suggestion that it may be related to a CNS involvement. A diffuse involvement should make you think of these four causes of encephalopathy. And today I'm going to talk about hyponatremia, which is one of the most common scenarios, which it is called metabolic encephalopathy, but metabolic encephalopathy we are referring to hyponatremia. And the other forms of encephalopathy, as you know, hepatic encephalopathy is because of ammonia crossing the blood-brain barrier. Uremic encephalopathy in renal failure because of accumulation of urea, and hypercarbic encephalopathy in type 2 respiratory failure because of the accumulation of carbon dioxide. So today I'll be mainly focusing on the various clinical scenarios. Encephalopathy I just told first because that is one of the most common presentations of hyponatremia. Another thing that we remember when a patient presents to you with hyponatremia is you always see this term SIBH. Okay, always if you take a case sheet or a discharge summary, you always see the patient has got sepsis, SIBH, hyponatremia, metabolic encephalopathy. So these are the common terms that you usually see when encountering hyponatremia. So what do you actually mean by SIBH? SIBH, the expansion is syndrome of inappropriate ADH secretion. Okay, so I'd just like to give a brief explanation into what it is. Kindly try to analyze each word. What do you mean by a syndrome? Syndrome is essentially a cluster of symptoms or two groups of symptoms that are seen together for which a causal association cannot be established. Say for example, you talk about a seizure. Seizure, as you know, is a manifestation of epilepsy. So is epilepsy and seizures the same? Okay, so if you look at the classification of epilepsy, only simple partial seizure. The old term is simple partial seizure. The current term is focal seizure without discognition. Simple partial seizure is the only kind of seizure for which a cause is known. That is, it can be because of hyponatremia, it can be because of hypoglycemia, it can be because of a stroke, it can be because of a space occupying lesion. So the cause is established in that kind of seizure, and that is why it is not included in an epilepsy syndrome. If you ask me what an epilepsy syndrome is, everything other than simple partial seizure is in the further subclassifications are there. So essentially syndrome, if you take say for example paraneoplastic syndrome, symptom complexes associated with a malignancy that cannot be explained by its growth by compression, cannot be explained by its growth by infiltration, cannot be explained by its metastasis to lymph nodes, cannot be explained by its metastasis to distant organs, nor can it be explained by hormones secreted if the hormones are secreted by the cells belonging to the tumor mass. So what does the definition mean? Essentially it means that you are trying to logically extrapolate all the ways in which a cancer or a malignancy can spread, and still you cannot find an answer, so you put it as syndrome. So basically a cluster of symptoms for which a causal association has not been established is known as syndrome. So now expand on inappropriate ADH secretion. So ADH, if you can expand on the word, what does it mean? It means antidiuretic hormone. So basically it is supposed to retain water in the body. That is what it means. So now you consider this typical case where you have say a serum osmolality of 320. So the ideal behavior of ADH is to bring down the serum osmolality normal, which is to 280 to 290. That is what is the appropriate behavior. That is what we mean by appropriate behavior of ADH, right? So what would be inappropriate ADH behavior? Inappropriate ADH behavior would mean that even if the serum osmolality is low, do you want to pull in water to further reduce the serum osmolality? You do not want to do that. So a condition where serum osmolality is low and still ADH is being secreted in excess is considered to be inappropriate, and we do not know why it is happening. That is why it is known as syndrome of inappropriate ADH. Okay, so that is one thing that I saw. Antidiuretic hormone, I will be explaining a little into the antidiuretic hormone, its metabolism, where it acts and how it causes hyponatremia, because the whole discussion will be centered around SIBH and we'll be branching off other causes of hyponatremia from there. Okay, so syndrome of inappropriate ADH secretion, there is excessive ADH secretion. So inappropriate can be less and excess, but in this case it is always excess secretion. For a low serum osmolality, when it has to it has to reduce the secretion, it increases the secretion. Okay, so another important term that will be constantly using in the discussion is known as pseudo hyponatremia. Pseudo hyponatremia. 2 into sodium plus blood glucose by 18 plus blood urea nitrogen by 2.8 or blood urea by 6. So this is the formula for serum osmolality. Many a time we need not calculate the serum osmolality because it will be given. You can have a direct lab report for the serum osmolality. So what are the things that you analyze from this formula of serum osmolality? This is a very important formula because there are a lot of concepts that can be derived from this formula. So if you look at it, sodium is the most important contributor of serum osmolality. If you look, blood glucose is being divided by 18, blood urea nitrogen is being divided by 2.8. So what can you analyze from that? Sodium is 18 times a more effective solute than blood glucose, and 2.8 times more effective than. So what does an effective solute do? So if you look at a bottle of water, okay, suppose there are a lot of solutes in the solvent. How can you actually make a water that is mixed with salt, a salty solution, less salty? One is to reduce the amount of salt that you mix in it. The other thing that you can do is pour more water. Okay. In most of the discussion today that is happening today, we are classifying hyponatremia into various classifications for the easiness in management, because management varies. You will be seeing that in most of it, it is actually not the sodium that is reducing. Sodium is reducing, that factor is only around 20% in which the sodium actually reduces. 80% is because the amount of sodium is normal. A lot of water is being pulled, which dilutes the amount of sodium. I hope you're understanding the concept. Suppose you're dividing a group of 10 students in a small class and then redistributing it in a larger class. The number of students per unit area will remain less when you try to redistribute. So what I'm trying to tell you is, when you add more water, or when there is the intravascular volume is being diluted with free water reabsorption, the sodium will appear less. So that is the pathophysiological mechanisms in most of the cases. Two into sodium plus glucose by 18 plus blood urea nitrogen by 2.8 or blood urea by 6. Okay, now you take into formula. So now from this formula, what do you mean by pseudo hyponatremia? So if a serum osmolality is to be high, it has to be contributed by sodium. So if the serum osmolality is high and still sodium is less, what does it mean? There is something else that is contributing to the osmolality, because the predominant component of serum osmolality should be sodium in the normal case. So that is how the term pseudo hyponatremia came into place. Okay, so pseudo hyponatremia, so if you can extrapolate from that, what does it mean? It is some solutes which are present, which are either not contributing to the serum osmolality from the formula, or something which is actually contributing to the osmolality which is present in abnormal amounts, which is contributing to the serum osmolality, and then sodium is less. Okay, so the initial step in the management is, I'll come to the management later, but you can just So the term, okay. So the next concept is effective solute and ineffective solute, okay. Suppose this is the cell and that is the intravascular compartment, okay. So effective solutes are those solutes which can pull in water from the blood to the intravascular compartment, okay. There are certain solutes which cannot do that, they cross the cell membrane. Certain solutes which do not cross the cell membrane will be able to pull in lot of water. So essentially pseudo hyponatremia is because of the presence of a solute, either a solute which is there in the formula of the serum osmolality present in abnormal amounts. So for example, hyperglycemia. Hyperglycemia is the most common encountered condition, hyperglycemia, okay. So if a patient comes to you with a low sodium, say 120, and his blood glucose is say 500, okay, it is the excessive glucose that is pulling in water, diluting the remaining amount of sodium, okay. So that is what it means. So the normal glucose, if we take it as 100, the extra amount that is there is 400, okay. So for each 100 increase in glucose, there is a reduction of sodium by 1.6, okay. So is it only pseudo hyponatremia in this case? What is the normal sodium value? It is taken 135. So the reduction is 15. Okay. How much are you supposed to reduce? 4 into 1.6. Okay. If you take it as 4 into 2, still it is only 8. So the reduction is more than that. Okay. So one of the examples of pseudo hyponatremia is hyperglycemia, and other effective solutes like protein, triglycerides, or if you take solutes like mannitol, glycine, all those are effective solutes. So those solutes, if it is present in the blood because of some metabolic abnormality, and it is that which is contributing to the serum osmolality, it is pulling in water and it is diluting the remaining sodium, and which is presenting as hyponatremia. So that is the concept of pseudo hyponatremia. So whenever a patient presents with hyponatremia, the first thing that we send is something which is known as a serum osmolality. Serum osmolality. Serum osmolality, as I told you, it is 280 to 290. So if the serum osmolality is high, say 300, then you can immediately stop the workup, okay? Because serum osmolality high and low sodium means that it is some other effective solute which is causing the high serum osmolality, which is pulling in water, which is reducing the sodium, okay? And if it is, say for example, hyperglycemia, you just give insulin or whatever. If you correct the sugar, the sodium will automatically increase, okay? That is why it has been categorized separately as pseudo hyponatremia. So I'll give you an example. A patient is coming with say altered sensorium. So before categorizing hyponatremia, you have to have an objective evaluation, objective evidence of the various levels of sodium. Okay, so European Society of Intensive Care, okay, according to the latest guidelines, the amount of sodium, okay, the hyponatremia is categorized into 3. If it is less than 134, it is mild. If it is 120 to 130, it is moderate. Less than 120 is severe, and less than 100 is very severe. Okay, this is the latest classification for the amount of sodium. So whenever you see a low sodium value, first thing that you have to do is you look whether the patient has got any type of symptom. Okay, 3 types of symptoms can be there. You can have gastrointestinal symptoms like nausea, vomiting. We are more concerned about the neurological symptoms. Neurological symptoms, anything that starts from a disorientation or seizures, syncope, any kind of a neurological manifestation can be there for hyponatremia. Okay, so you expect symptoms, you can expect symptoms. Another important thing that you have to remember is whenever a patient present with hyponatremia, you have to always look for this drug, hydrochlorothiazide, in the drug chart. Okay, thiazide diuretics are very notorious for causing hyponatremia because they make all parts of the nephron sensitive, and water is being pulled in from all parts, reabsorbed being from all parts. So first, any patient, regularly a hypertensive patient coming to you, hydrochlorothiazide, if it is there in the drug chart, you have to immediately stop it. Okay, so patient has come to you with say a low value of sodium, say 125. Okay, also you have to look at what was the baseline value of sodium. Many patients have something which is known as a chronic hyponatremia, in which the sodium values are usually very low, say usually maybe around 128, 129. In such patients, you have to look for the decrease from their baseline value and then associate it with the symptoms. At the same time, you have to also side by side evaluate for the other causes of encephalopathy also. Just because you have made an association with low sodium and encephalopathy, it doesn't mean that the patient has only that. Okay, like usually what we see is a patient with infection, he can have septic encephalopathy. Along with that, he can have a renal function altering. So a type 2 respiratory failure, because so you have to remember that multiple conditions coexist in the same patient. So just because you associate encephalopathy to hyponatremia, it doesn't mean that the other factors you shouldn't evaluate. Okay, so the next thing is about ADH. Okay, so I told you the most common cause of hyponatremia in our setting is SIBH, and I told you how it happens. It is because of the inappropriate secretion. So you have to know a few details about where ADH is secreted from. ADH is actually said to be a hormone of the posterior pituitary, but it is secreted from the supraoptic and paraventricular nucleus, moved from the supraoptic nucleus of the hypothalamus, and the hypothalamus has got an osmoregulatory center, and it is the hypothalamus, as I told you earlier, hypothalamus which decides. Okay, so when your serum osmolality is high, ADH will be secreted to bring the serum osmolality to normal. Okay, and thirst centers is also regulated by the osmoregulatory centers in the hypothalamus. So ADH and oxytocin are secreted from the supraoptic paraventricular nucleus of hypothalamus. They are stored as hormones in the posterior pituitary as granules and then released as hormones from the posterior pituitary. I'll be explaining a little bit about ADH here, because ADH is if you understand the concept of why ADH causes hyponatremia, the other causes of hyponatremia will also be easy to understand. Okay, so ADH, as I told you, it is released as hormones of the posterior pituitary. It has got three group of receptors, V1, V2, V3. V3 receptor also called V1B. So action of ADH on V1 receptors. Okay, ADH on V1 receptors, it causes myocardial hypertrophy, glycogenolysis, uterine contraction, platelet aggregation, and vasoconstriction. These are the action of ADH on V1 receptor. ADH, you have to remember that it is secreted as a precursor molecule which is known as ADH. The other name for ADH is also known as vasopressin. Pre-pro-arginine vasopressin divides into neurohypophysin, copeptin, whose functions are not known, and arginine vasopressin, or ADH, or vasopressin as you normally call it. So that is why, because it causes vasoconstriction, that is why it is used, vasopressin is used to constrict blood vessels. Okay, what about the action of in the V3 or V1B receptors? It stimulates ACTH release. It stimulates ACTH release from the ACTH release from the anterior pituitary, which acts on the adrenal and other adrenal glands. Okay, so ACTH release. And what about V2? V2 has got two actions. One is aquaporin 2, and the second action is von Willebrand factor activation. So many of the times you see that a patient with hyponatremia has been diagnosed as SIBH. I will tell you how to diagnose SIBH. Will usually have low platelet, and when you do a peripheral smear, you will see that the platelets are clumped together. That is probably because of one of the mechanisms, maybe because of the activation of activation of the von Willebrand factor, which causes platelet adhesion. Okay, so that is one point you have to remember here. So now coming to the main action, which is, so these are actions which are not necessary for our current discussion. If you look at the main action, what we are discussing here is, so last presentation in hypokalemia, I had told you how RAS get activated, the three activators of renin, beta receptors, prostaglandin E2, I2, and reduce renal perfusion. That pathway will have to be used here, and the other pathway that we need to use is, you have to remember, ADH is again just like aldosterone. It passes unfiltered through the afferent arteriole, efferent arteriole, and peritubular capillary plexus. It binds to the basolateral membrane. Okay, it binds to the basolateral membrane of the cortical collecting duct. Okay, similar to aldosterone. Okay, in aldosterone, what did I say? It activates the epithelial sodium channel. Here it expresses something which is known as a cyclic AMP. cyclic AMP. So and expresses, once the cyclic AMP is activated, it expresses on the apical surface of the cortical collecting duct, it expresses something which is known as aquaporin 2. Okay, you have to remember this pathway very carefully. We'll be using it again and again in the discussion. So ADH passes through the efferent arteriole, peritubular capillary plexus, binds to the basolateral membrane of the cortical collecting duct. Instead of the epithelial sodium channel which the aldosterone activates, it activates cyclic AMP, which expresses aquaporin 2 on the apical membrane of the cortical collecting duct and causes free water reabsorption. Okay, so here you have to remember another thing. Okay, so what I have drawn here, I have tried to draw here the Bowman's capsule and the glomerulus. Okay, it's called the renal corpuscle. Okay, now I'm going to talk about how aquaporin 2 expression causes hyponatremia, how it causes free water reabsorption. Okay, so what you can understand is what is the blood osmolality? 280 to 290. And urine osmolality is around 800 to 900. Okay, you know that your urine is more concentrated than the blood, and if you look at the pH, the urine pH is around 5, blood pH is around 7.4. That all of you know. Now, how does this 280, 290 becomes 800, 900 in the osmolality? That happens something which is known as the counter current exchange mechanism. I'll be explaining that here. So here the blood passing, it has an osmolality of 285 when it undergoes something which is known as an isoosmotic reabsorption. Okay, so why is it called isoosmotic reabsorption? Because the whatever osmolality of the blood was there, here it is the same after it passes through the proximal convoluted tubule. Okay, it's an isoosmotic reabsorption that happened because the osmolality has not changed. Here the osmolality becomes 1200. Okay, so what you can see, the 285 has become 1200, so the osmolality has multiplied. So this is called counter current multiplication. Okay, 285 has become 1200, and that DCT, the osmolality is around 50. Okay, so here what has happened? The water has been reabsorbed from the PCT to the loop of Henle. Water has been absorbed, so the osmolality has risen. Here solutes are reabsorbed, so the osmolality becomes 50, and from here, here is where the aquaporin acts. Okay, aquaporin expressed on the apical membrane of the cortical collecting duct, and from 50 free water reabsorption takes place and it becomes the 800, 900. Okay, so this is what is happening in the kidney. Okay, so if you look at the aquaporin 2, you have to understand that there is a lot of free water that is being reabsorbed in the place where it is exempt. So the same situation that I told you, we have salt and water. You add more water, the salt gets diluted. Okay, it's not a reduction in the absolute amount of the molecule, it is the dilution that is happening. That is what is happening in most cases of hyponatremia. Now we are talking about SIADH only. Okay, I need to discuss a few points here. So I told you free water reabsorption. Okay, free water reabsorption that is happening via aquaporin 2, which is expressed on the apical membrane of the cortical collecting duct because of the activation of cyclic AMP. This is known as facultative water reabsorption. So again, focus on the word. What do you mean by facultative? Facultative essentially means that you are using a faculty to reabsorb water. What is the faculty here? ADH. Okay, so ADH that is coming from the posterior pituitary is expressing aquaporin to reabsorb. That is why it is called facultative reabsorption. So facultative reabsorption happens because of aquaporin 2. Okay, there are other sources of free water absorption, like for example, if you take aquaporin 1 and aquaporin 7. Okay, aquaporin 1 and aquaporin 7, they are found on the proximal convoluted tubule. Okay, there the water reabsorption is called the obligatory water reabsorption. Okay, there is no particular faculty, there is no particular molecule that is expressing something. It happens on its own. Okay, you are obligated to do that. So that the water reabsorption that happens in the proximal convoluted tubule is known as obligatory water reabsorption because it doesn't use ADH. Okay, you also have other aquaporin molecules like aquaporin 3 and 4, which is expressed on the basolateral membrane of cortical collecting duct, aquaporin 6, which is found in the vesicles of the cortical collecting duct, those can. So the important terms that you have to remember, reviewing on whatever I have told till now: aquaporin 1, aquaporin 7, obligatory water reabsorption, free water reabsorption because of aquaporin 2 and because of ADH, and also the essential terms. What is pseudo hyponatremia? Some other effective solute other than sodium, which is supposed to contribute to the osmolality, is contributing to the osmolality, driving in water, diluting the sodium. Okay, and we have told about the various mechanisms by which ADH acts. Another important concept that you need to remember in hyponatremia is, I am drawing two containers here. Okay, one is a small container with a capacity of 100 ml. This is a capacity of 500 ml. Okay, so you're filling both the containers to its adequate capacity. From where to where the water will flow. So in physics, we have learned that always whatever it is, air or water, moves from a concentration of higher concentration to lower concentration. So it is very simple here. Water will flow in this direction from a higher concentration to a lower concentration, and this will start overflowing. Okay, now what is going to happen if we add some solutes to it? Suppose in both solutions, we are this is very much in relation to whatever we are going to talk now. Suppose we add sodium chloride, okay, and make the osmolality 300, and here you make the osmolality 260. Okay, there is what the difference happens. Okay, when you add salt and you make normally the water has to flow from here to here. Here now, because you are making the solution hyperosmolar, the water will flow in the reverse direction. So the message that I want to tell you is that whenever there is a solute and a solvent, the law of physics is not applicable here. Okay, it is the relative concentration of the solute and solvent. Okay, water will always move from a area of a lower osmolality to an area of the higher osmolality, because in relation to the amount. Why I told you that is because of something that I want to describe here. Okay, so I told you that it is the neurological manifestation that is the most common. So why does neurological manifestations happen in hyponatremia? I told you there is a lot of free water reabsorption, and the water is moving from the blood compartment to the brain, causing cerebral edema, raised intracranial tension. That is what. Okay, so brain and blood. Okay, so water is moving from the blood to the brain compartment. That is not very difficult to imagine, because the water always will be more in the body than the brain. So water will move from a higher concentration to a lower concentration. But again, I will be explaining something which is known as an osmotic demyelination. That is what has happened if you excessively correct the sodium. There, the brain is actually shrinking because the blood flows from the reverse direction. So just I had shown you the two vessels. You would have found it abnormal that the water moves from a smaller container to a bigger container. Similarly, that can happen if there is a sudden change in osmolality, which is known as osmotic demyelination. Water can move from the brain to the blood. Brain is actually shrinking. So that is one of the complications for a sudden change in osmolality, which I will be explaining later. Okay, so that much you have to remember here. So it is not the absolute concentration of the solvent. When there is a solute and a solvent, it is the relative concentration which decides where the water is being driven to. So I told you, first when a patient comes to you, you look for presence of neurological or gastrointestinal symptoms, classify as hyponatremia, look for, send for serum osmolality. If the serum osmolality is high or normal, then it is a pseudo hyponatremia. You look for the presence of effective solute. Mainly we look whether the patient has got hyperproteinemia, hyperlipidemia or hyperglycemia. Most common is hyperglycemia. You correct the glucose, that is for each 100 glucose reduction you will get an increase in sodium by that. Okay, the other workup that we send is along with serum osmolality, we send urine osmolality and urine sodium. Okay, so why do we send these two workups? So I told you hyponatremia, the most common cause clinical encountered scenario is SIADH. So it is, the discussion will be completely centered around SIADH. It is to rule out SIADH that this thing is happening. Okay, so the actual evaluation of hyponatremia, you should proceed only if the serum osmolality is low. Okay, I told you serum osmolality is less than 280. So now if you look at any textbook, they say there are 5 criteria to be satisfied for SIADH. Okay, first is what the patient should be euvolemic. Secondly, the blood should be hypoosmolar, or the osmolality of the blood should be less than 280. Second is two different textbooks have given two different values. Some say urine osmolality more than 100, some say urine osmolality more than serum osmolality. The third criteria, so three criteria over: euvolemic status, hypoosmolar blood, hyperosmolar urine, and urine sodium more than 20. And the fifth criterion is absence of pituitary, adrenal, thyroid, liver or renal disease. Okay. So we have sent for the workup. Suppose the serum osmolality is less. The next thing that we have to do is look for the volume status of the patient. Volume status of the patient. Okay. So the patient can have three kinds of volume status. He can be hypervolemic, euvolemic or hypovolemic. So how do you know? First thing, you can look for signs of dehydration in the physical examination of the patient. What is the next thing that you can do? You can look for the urea creatinine ratio. If the urea creatinine ratio is more than 20, it can suggest that the patient is probably having a dehydration or a hypovolemic hyponatremia. Okay, so after ruling out pseudo hyponatremia from the serum osmolality, then you send the urine osmolality and urine sodium. Okay, so urine osmolality, if it's more than serum osmolality, urine osmolality is more than 100. Euvolemic status. Hypoosmolar blood. Urine sodium more than 20. Okay, so in SIADH, why does the urine sodium become more than 20? That is the next concept that I want to derive here. So I told you, other than the nephron, another important thing that you have to remember, again we will use the renin-angiotensin aldosterone mechanism, which we used in the last presentation. The three stimulators of renin: beta receptors, prostaglandin E2, I2, and reduce renal perfusion. Okay. Basolateral membrane, aldosterone binds, activates the epithelial sodium channel, throws out proton, throws out potassium, throws out proton, takes in salt and water. The two important things that you have to remember is whether this axis, RAS axis, is down-regulated or up-regulated. So you have to focus on this. Reduced renal perfusion causes up-regulation of the axis, and as a result of which there is salt and water retention. If there is a down regulation of this axis, that is, if there is something that is causing increased renal perfusion. So most cause of hyponatremia, I told you, there is some solute or some form of a water reabsorption that is happening, which is diluting the sodium. Other than diluting the sodium, what does water reabsorption do? It increases the intravascular fluid volume. It will increase the renal perfusion. When renal perfusion is increased, there is a down regulation, the aldosterone, the down regulation of the RAS axis, as a result of which what will happen? There will be salt and water wasting in urine. Okay. So I told you, one of the reasons for hyponatremia is the dilution of the excess water being pulled in SIADH and other conditions as well. In other conditions, how it happens, I'll explain. And the second reason is the loss of sodium in urine. The loss of sodium in urine happens because of the transient increase in the intravascular fluid volume and increase in renal perfusion. These 2 points you have to remember. It is very important. So you have got that serum osmolality is less than 280. Second thing, you will always see thyroid function and random cortisol. Why do we send thyroid function and random cortisol? So the three important differential diagnoses for euvolemic hyponatremia are SIADH, hypocortisolism, hypothyroidism. So even after, and if you remember the fifth criteria, absence of pituitary, adrenal, thyroid, liver or renal disease. Only if that satisfies, all 5 criteria are satisfied, you can say that it is an SIADH. That is why once the patient is euvolemic, and if the serum osmolality is less, and if it is, so it is a true hyponatremia. It is to satisfy the fifth criteria that we send for thyroid function test and random cortisol. If there is an abnormality which showing a hypothyroidism or hypocortisolism, we cannot write the diagnosis as SIADH. Okay, so SIADH, I told you how it happens. Okay, now let us consider the other possibility. Okay, what are the causes of a hypovolemic hyponatremia? So I told you, if the patient is dehydrated. So what are the causes? Hypovolemic hyponatremia can be again divided into renal and non-renal causes. Renal and non-renal causes. The renal causes are Anything that causes a fluid loss, vomiting, burns, and any cause of third space loss, that is rhabdomyolysis, burns, and non-renal causes of vomiting, diarrhea, burns, rhabdomyolysis, and pancreatitis. Okay, vomiting, diarrhea, burns, rhabdomyolysis, pancreatitis. These are the non-renal causes. So the patient will have the volume status will be depleted. And the renal causes are acute kidney injury, renal tubular acidosis, excessive use of diuretics, and hypoaldosteronism, and also something which is known as a cerebral salt wasting syndrome. Okay, so again and again we will be using this renin-angiotensin-aldosterone mechanism in our discussion. Okay, so now you think about why a hypovolemic hyponatremia causes hyponatremia per se. Okay, so the patient's intravascular fluid is depleted. So when the intravascular fluid is depleted, what will happen? The renin-angiotensin-aldosterone mechanism is activated. So when the renin-angiotensin-aldosterone mechanism is activated, there is salt and water reabsorption. So you should think that when salt and water reabsorption happens, the salt should go up. It should actually present with a hyponatremia. But why does it present with a hyponatremia? So as I told you, when I wrote the formula 2 into sodium plus glucose by 18 plus blood urine nitrogen by 2.8, the sodium is a very effective solute. So when one sodium is reabsorbed, it absorbs a disproportionately larger amount of water, which dilutes the remaining sodium. That is what it actually happens. So once again, I'll tell you, the reduced renal intravascular fluid volume is reduced because as you can see in all the causes, the fluid is going out. So what will happen? Salt and water reabsorption happens. So when salt and water reabsorption, you should think that it should cause hyponatremia, but because sodium is an effective solute, from the formula of the serum osmolality, it is 2 into sodium plus glucose. But I told you sodium is one of the most effective solutes. So when one sodium is being reabsorbed, the amount of water that is reabsorbed is disproportionately large, which will dilute the remaining sodium. So that is the reason for any of these cases. So if you concentrate on this, cerebral salt wasting syndrome is a very important differential diagnosis for SIADH. I have not told you about the causes of SIADH. The most important cause of SIADH is head injury. Okay, so when a patient has head injury, what happens is he can either present with a hyponatremia because of SIADH, as well as it can present with cerebral salt wasting syndrome. So if you have been to the ICU, you would have seen that in some patients the BP suddenly fluctuates. Well, at one moment you see that the BP is high, then the other moment you see that the BP is low. This happens because of autonomic dysregulation. Okay, so when there is autonomic dysregulation in a patient with head injury, it down regulates the beta receptors, and beta receptors, I told you, is a stimulation for RAS axis. When the beta receptor is down regulated, what will happen? There will be salt and water excretion in the urine. So the three important factors to distinguish the closest differential diagnosis, that is cerebral salt wasting syndrome, is first, as you have already seen, this is a cause of hypovolemic hyponatremia. Hypovolemic hyponatremia because salt and water is being excreted, that you have understood. And what are the other reasons? So cerebral salt wasting syndrome usually doesn't present with a sudden onset, like in 1 or 2 days it doesn't present like SIADH. It will take around few days or at least a week time to present. The resolution is also slow. Okay, but in SIADH, once you have done the treatment, the appearance is fast, the resolution is also fast. And the third difference is you would have studied in pharmacology, probenecid is a uricose uric drug. Similarly, ADH is also a molecule which excretes uric acid in urine. So uric acid will be low. Even though it's not there in the criteria, it is one of the important distinguishing factors which will help in distinguishing from cerebral salt wasting syndrome. Okay. So the patient has come to you, you know that the patient has got low sodium, take a history of the patient properly, look for thiazide diuretics, presence of diabetes. If the blood sugar is high, a strong thought of pseudo hyponatremia should be kept in mind, and the glucose should be corrected. If the serum is hypoosmolar, it is a true hyponatremia. True hyponatremia can be divided again into hypovolemic hyponatremia, euvolemic hyponatremia, and hypervolemic hyponatremia. Euvolemic hyponatremia is SIADH with two different important differential diagnoses, which is hypothyroidism and hypocortisolism. So as soon as you see the serum osmolality is low, you should send the thyroid function test and cortisol levels, random cortisol levels, and also send for the urine osmolality and urine sodium. And all the 5 criteria has to be satisfied. That is hypoosmolar, that is blood osmolality less than 280, urine osmolality more than 100 or urine osmolality more than serum osmolality, euvolemic status, urine sodium more than 20, I told you why it happens, and absence of adrenal, pituitary, thyroid or liver or renal disease. So in that, the adrenal and cortisol is coming, you do that. If it is a hypovolemic, now we are differentiating into hypovolemic, euvolemic, hypovolemic because the management in each is different. Okay. Now the third type is something which is known as the hypervolemic hyponatremia. So in hypervolemic hyponatremia, any condition that causes a fluid overload, which causes a pitting pedal edema. So like for example, you can see CLD patient because of various pathophysiological mechanisms, you can have pedal edema, ascites and things like that. Patient with CKD, patient with nephrotic syndrome, patient with congestive cardiac failure. I'm not going into the detail of the mechanisms why it happens. All of you might be knowing it. So here also there is hyponatremia. Okay, so you should, I have noticed this question being asked by a lot of people. Is it in this excess of water? Patient is volume overloaded. Is it this excess of water that is diluting the sodium? If you ask me, the answer is no. Okay, because the amount of fluid in the particular person's body is same. The intravascular and extravascular, the total amount of fluid is same. Here in all these cases, if you notice, the fluid is in the extravascular space. So when there is more fluid in the extravascular space, the amount of fluid in the intravascular space will be less. So again, the amount of intravascular patient, even though he's looking volume overloaded, his intravascular fluid volume is less. His intravascular fluid contracted. As a result of which, there is activation of the renin-angiotensin-aldosterone mechanism. Here also, it should be a hypernatremia because there is salt and water reabsorption. But as I told you, sodium is an effective solute. The amount of water absorbed is disproportionately large when compared to one sodium absorbs so much amount of water and the remaining sodium gets diluted. Okay, so now you would be asking me another question. If the mechanism is same, why is the management different? Okay, so the management of hypervolemic hyponatremia is usually with diuretics. We prefer loop diuretics. We never give thiazide diuretics because I told you thiazide diuretic is very notorious for causing hyponatremia. Even though it contracts the intravascular volume a little bit, it will absorb a lot of water which will dilute the sodium. So thiazide we do not. We usually prefer loop diuretics. Okay. On the other hand, for hypovolemic hyponatremia, we give her the normal saline, 0.9% normal saline. Why do we give normal saline? And for the other thing, why do we give Lasix? So you understand that if we give normal saline in a case of hypervolemic hyponatremia, whatever fluid we are giving that fluid to expand the intravascular volume, it will go into the extravascular space because of whatever mechanisms that I mentioned. So it will not be of any effective. But in the hypovolemic hyponatremia, if you give the fluid, because there is no pathogenic mechanism causing to push it to the extravascular space, it will increase the renal perfusion and correct the defect. Okay, now coming to the management of each. Okay, so hypovolemic. So in the management of sodium, what you have to remember is you have to correct what is necessary. Okay, so in euvolemic hyponatremia, usually if the patient is symptomatic, we correct with 3% NS. For hypovolemic hyponatremia, we correct with 0.9% NS. So why do we correct with 0.9% NS? There we are trying to correct the volume more. We want to correct the sodium little bit also. Okay, so if you look at the serum osmolality, 0.9% NS contains 154 milliequivalents per liter of sodium. 3% NS contains 513 milliequivalents per liter of sodium. And okay, so this is the difference. Okay, so in hypovolemic hyponatremia, you want to correct the sodium little bit, but volume is what you're more interested in correcting. Okay, so now I'll tell you how you manage each condition. Okay, so if the patient is presenting with hypovolemic hyponatremia, I told you the preferred solution is 0.9% NS. 0.9% NS. And another thing that you have to know is whenever you're correcting the hyponatremia, you have to know how much the sodium might increase. Okay, how much the sodium is increasing is given by the formula infusate sodium minus serum sodium divided by total body water plus 1. Total body water is 50% of the body weight for females and 60% of the body weight in males. So I'll just give you a scenario. A patient presenting who looks dehydrated and has got a cause of dehydration as well, any of the causes that I mentioned, and the sodium is say 125. Okay, so how much of sodium is increased? Okay, so this I told you contains 154 minus 125 divided by, let us say that the body weight of the person is around, it's a female of 60 kilo body weight. So half of that 30 plus 1. Okay, so approximately 125 minus 154, 25 plus 25 is 50, 29. Okay, so it will be around 29 by 31. Okay, so around 1 milliequivalent. Okay, 30 by 30 is 1. So around 1 milliequivalent rise of sodium will happen if you give, this is I told you 154 milliequivalents per liter. So if you give 2 pints, that is 1 liter of 0.9% NS in a patient with sodium 125, that much is how much that the sodium will improve. We do not want a very high improvement of sodium for here, because when the volume status is corrected, automatically the sodium will get corrected. The sodium correction is mild. Okay. Now, the most important correction that we need to remember is if the patient has got a euvolemic hyponatremia and you have diagnosed SIBH and the patient is symptomatic. Okay, so as I told you, sudden change in osmolality can cause problems. So we are worried about this complication known as osmotic demyelination. Earlier the term was central pontine myelinolysis. As I told you, it is the water shifting from the brain to the blood. As a result of which the brain shrinkage happens. So we don't want that to happen. So maximum the amount of sodium that can be corrected per day is 8 milliequivalents. Okay, so now I'll put it into a clinical scenario. 121 is the sodium. Okay, so as I told you, 513 milliequivalents per liter is the amount. So 513 minus, so how much of 3% NS you can give is the question. That is what I'm answering. 513 minus, okay, instead of 121, let us take it as 113. Okay, just for the ease of calculation, 113 divided by same, okay, a female with 60 kilos body weight, so 50% of the body weight, 30 plus 1. Okay, so this will come to 400 divided by 13. So this will be around 40 by 3, 4 by 3. So around 12 milliequivalents will be corrected if you give 1 liter. 12 milliequivalents will be corrected if you give 1 liter, and the normal saline comes in 100% bottle. Here we give an infusion pump like 30 ml per hour, 30 ml per hour, 15 ml per hour and things like that. So how much you have to give? So 1 liter when you correct, or 10 bottles when you correct, it will rise by 12. Do you want such a high rise? No, we do not want. The maximum that can be corrected is 8 milliequivalents per 24 hours, because otherwise it can cause osmotic demyelination. So how much bottles of this thing can we give? You can give around 8 bottles over 24 hours. Okay, so if you start an infusion pump at 30 ml per hour, 100 ml bottle, it will finish in almost 3 hours, right? 30 ml per hour. So if you can give 4 bottles over how much hours? 1 bottle finishes in 3 hours. 4 into 3 over 12 hours, you can correct 4 into 1.2. That is around 6 milliequivalents we can correct, which is a safe correction. Okay, even though we calculate like this, sometimes when we correct, it might be a little different from what we have actually corrected, because there are many mechanisms playing. So on the safer side, we can correct around 4 bottles in 24 hours. It will go around 12 hours, or if you reduce the infusion rate to 15 ml per hour, it will go in a higher amount of time. Okay, so that is what we can do in the correction. So acute symptomatic hyponatremia, if you have proved that it's a euvolemic hyponatremia and all the criteria of SIBH we started, we want more solute. So you give 3% NS. Hypovolemic hyponatremia you give, and you know how sodium increases in it. Okay. Now the second important concept is, many times we get reference for correcting hyponatremia. It may be around 3 or 4 days in which the patient has had hyponatremia. So one important thing that you have to remember is, if the sodium is low for more than 48 hours, then if we give even a little amount of 3% NS, that is not more than 8, even less than 8, it will cause a sudden shift in osmolality. Okay, I told you brain and blood. Okay, so the brain would have already adapted trying to throw out water from brain to blood, and the brain would have shrunken in size a little bit already over the 48 hours, and plus you give 3% NS, even if it's for a small amount, the osmotic demyelination chances are higher. So whenever it is a chronic hyponatremia, only a symptomatic hyponatremia you need to treat, and you need to treat it very cautiously. You should not rise it suddenly. You have to calculate first and repeat the sodium values and see. And if it is a chronic hyponatremia which has lasted for more than 48 hours, then you do not need to give 3% NS. You just need to give water restriction. Okay. water restriction of around 800 ml per day, or added salt like around 6 to 8 grams per day, and keep monitoring the sodium, evaluate for the symptoms, and now side by side other cause of encephalopathy should also be corrected. What about hypervolemic hyponatremia? If the patient presents with any of the things of hypervolemic hyponatremia, the treatment is furosemide or Lasix injection you have to give to throw out. The sodium will automatically get corrected. So true hyponatremia divided into 3 arms. I told you how to correct each. Okay. Next we are talking about hypernatremia. Okay. Hypernatremia is usually common only in patients who are in a comatose state. Okay, the patient, as I told you, the osmoregulatory center is in the supraoptic nucleus. It maintains ADH as well as the thirst of the patient. So it's usually patients who are not drinking water or getting hyponatremia. Whenever you get a hyponatremia, say the patient has a sodium of say 163. Okay, first thing that you have to do is calculate the water deficit. Calculate the water deficit. The water deficit formula is given by 0.6 into body weight into 140 minus serum sodium divided by 140. Okay, so that is 0.6 into body weight. We will say take the same case. So there it was body water, here it is body weight. So 60 into 23 by 140. Okay. 140 minus 163 divided by 140. So 0.6 into 1, this thing is almost, you can take it as 0.6. This is 36. Okay. 0.6 into 60 is 36 into 23 divided by 140. Okay. So if we take this as 20, 35 to 2, almost 700 divided by 140. Okay. It will be coming around to 5 to 6 liters. Okay. So in hypernatremia, the other important, you can apply the same formula in correcting the hypernatremia also. We do not want a sudden change in osmolality. So when you are reducing the serum osmolality also, you reduce it by a maximum of 8 per day. 8 milliequivalents per 24 hours. Okay. So whether can we give this 5 liters depends. So suppose you are giving half NS. Half NS contains half of 154, 77. Okay. Infusate sodium minus serum sodium. Serum sodium is 163 divided by total body water plus 1. Okay. So you have to look into the whole clinical scenario. If the patient is already volume overloaded and the patient has got hypernatremia, you want to correct the sodium, bring down the sodium suddenly by giving lesser amount of water. So it is very easy to imagine. See, 5% dextrose, free water and all contain no solute. So the infusate sodium will be 0. So there, if the patient is hypervolemic, you want to correct the sodium suddenly. So you give, it is better to give half NS, because lesser amount, the higher amount of sodium can be corrected by giving lesser amount of fluid. Okay. But on the other hand, if the patient is dehydrated or in other conditions where, like for example, patient is having a paraneoplastic related hypercalcemia, there's a lot of fluid loss, you want to replace a lot of fluid, you prefer free water through RT or even 5% dextrose. So in that case, the sodium can be corrected at a slower rate, but the more important is correcting the water. So these are the clinical scenarios. So briefing into the whole session. So now you have understood the pathophysiology of everything. So a patient coming to you with a low sodium, only if it is symptomatic you need to treat. High, severe, very severe, moderate, mild. I've told you what is the latest guideline of classification. Also you have to consider the baseline sodium of the patient. If the patient is symptomatic and correspondingly after looking for all causes of encephalopathy, you do a serum osmolality. If serum osmolality is high, you immediately consider pseudo hyponatremia, and most common cause is diabetes. You correct that, automatically the sodium will become corrected. Divide the patient based on the volume status into hypovolemic, euvolemic and hypervolemic. Hypovolemic, the causes can be again divided into renal and non-renal. Non-renal causes are vomiting, diarrhea, pancreatitis, burns, rhabdomyolysis. Renal causes are renal tubular injury, renal tubular acidosis, hypoaldosteronism, cerebral salt wasting syndrome, and excessive use of diuretics. Cerebral salt wasting syndrome is the most closest differential diagnosis, not in relation to the volume status, but in view of the presentation. I told you how to distinguish that. Euvolemic hyponatremia, hypocortisolism, hypothyroidism, and SIADH, and hypervolemic hyponatremia, and the correction of each. For SIADH, you need, if it's symptomatic, you need to give 3% NS. If it's a chronic hyponatremia, you can, instead of salt restriction, there is also a V2 receptor antagonist, tolvaptan, you can give. Okay, you can start at 15 mg per day. Okay, tolvaptan you can give 15 mg per day. Chronic hyponatremia or a non-symptomatic hyponatremia, you do not need to correct. The treatment is with salt, additional salt and water restriction, or with tolvaptan. And the hypovolemic hyponatremia, you give fluids, preferably 0.9% NS. For both the calculation is the same. And for hypervolemic hyponatremia, you treat with diuretics, and the preferred diuretics is Lasix. Never give thiazide diuretics. And for the and after doing all this, for hypernatremia, the formula is the same. You have to reduce only by 8 per day. First calculate the water deficit, and again give half NS or 5% dextrose or free water, depending upon what the need of the patient is. If the patient is hypervolemic, it is preferred to give half NS. If it is hypovolemic, it is preferred to give 5% dextrose. So I think that brings us to the end of the whole session. I think I've touched upon all the various clinical scenarios and the pathogenic mechanisms and how you need to correct it.